Good morning, everyone, and thank you for joining us in this town hall meeting, COVID-19 Speaking from Science. I want to thank my colleagues here who volunteered their time of the day to come here to help answer questions about the COVID pandemic, vaccination, treatment, and other questions that we received through the email. To introduce my colleagues, Dr. Ilyas Maroun. He's an ID specialist, infectious disease specialist. He's the antimicrobial stewardship chair at UF Health Central Florida. He's also the COVID-19 team leader at UF Health Central Florida. Then I have Dr. Hardik Bhatt. He is board certified in the internal medicine and also pulmonary critical care. He did his fellowship at Heinemann Hospital at Drexel University. And last but not least, Dr. Kevin Burns. He's the Chief Medical Officer of the UF Health Central Florida. He actually has a very impressive track record. He is a graduate of Mayo School of Medicine and actually completed general surgery residency there. He started University of Florida 2005, and he also had a tenure at St. Louis University. And then he joined UF Health Central Florida last year as the Chief Medical Officer. I'm honored to be with this group of distinguished physicians. These physicians are the ones who treat the COVID patients at UF Health Central Florida, Leesburg Regional Hospital, and the Villages Hospital. So we figured you hear it from them about the situation of COVID locally here, and also they will answer questions in general regarding COVID. I would like to thank Lakeview Healthcare, Leesburg Partnership, and the City of Leesburg, Ocala Lung Critical Care, UF Health Central Florida, and Red Apple Media for their support of this program. We really appreciate that. So I will give each of my colleagues here a few minutes just to give us a general idea about COVID and what's going on locally, and each will talk about his, from his perspective, and then we'll open it for questions. The main reason we organize this is mostly because we get a lot of questions from patients, relatives, friends about COVID, treatments, the vaccine, mask, all kind of questions. There's a lot of information out there. Trust me, these physicians are the ones who are every day battling that disease, and they can give us a better idea about how things are and what from their experience, they, from the data, research, and their experience, that's where answer is gonna come from. This is, COVID is a pandemic that's been out for almost a year and a half. So medicine is not obsolete. What we learn that can work today, we might find out that it might not work in the future. So it's an evolving science. We know that there are a lot of treatments or preventative measures that work, and we learn every day something new about those measures and treatments. So this is like looking at how medicine evolves. Usually in certain treatments, it might take 20 years. Now we are at warp speed. We're trying to learn every day so we can fight that pandemic. It's really like a fighting in a war, and we try to gather as much information, learn from it, and find the best ways to fight it and to minimize the casualties. So I'm hoping that this educational session will help answer a lot of your questions and maybe stimulate other questions that you can ask your healthcare provider, and do your part in trying to really help us get back to our normal lives. So I will start with Dr. Burns.
Great. Thank you, Dr. Hussein. It's really my pleasure to be here this morning to share with you our experiences at UF Health Central Florida. As a Chief Medical Officer, my job is to really help facilitate the care patient, bring that care to make sure that we have the resources to deliver that care efficiently and effectively, and to make sure the patients get the highest quality care. In the next few minutes, I want to share with you the impact of the pandemic on the hospitals locally. And so I'm going to put out quite a few numbers, but I'll try to put them in context so that you can understand, and I can try to give you a mental image of what goes on inside both hospitals each day. So if you look across the U.S. and if you follow the CDC data, you see that about anywhere from 120 to 150,000 patients test positive today. So that's countrywide. But what happens here locally? If you look at our hospitals, the Villages Hospital has about 307 beds, and on any given day, we will have about 225 or so staff beds. And of those beds, about 70 of those beds have patients that have COVID in it. So of 1/3 of our staffed beds have COVID patients. Some of those are in the ICU. At the Villages, we have an 18-bed ICU. And that has been pretty full over the last several weeks. If you look at Leesburg Hospital, there are about 350 beds in the hospital, and on any given day we'll have about 240 to 280 patients that are in staffed beds, and of those, 80 patients will be COVID patients. And there's a 16-bed ICU that has generally been full of patients over the last several weeks. So to give you kind of an example of how things have progressed over the last couple months, on June 15th, in both hospitals, we had a total of 6 COVID patients. We were very happy because at the Villages, at times we had no patients with COVID in the hospital in the middle of June. And so we thought that this pandemic was nearing its end. But then we started to see a steady rise over a few weeks. And really by mid-July, we had went from 6 patients to 50 to 100. And then this week, we really had our high. In both hospitals, we had a combined total of 169 patients, with the ICUs that were overflowing and a difficult time identifying beds for the patients. So you could see that in the course of 2 months, we went from almost having the pandemic whipped, we thought, to having a full-blown explosion of the virus in our communities. And every day at 8:30, we have a phone call that reviews the data to say how many patients we have in the hospital. So I want to give you this morning's report, right? I'm going to just give you the numbers as I received them, okay? Now, we're fortunate in that the last 2 days, Tuesday was our high of 169 patients. Then we dropped into the 140s for a couple days. And today, we're at 136 patients between the 2 hospitals. And this is our low since about early August, okay? So 136 patients. We have 19 patients in the ICUs. We have 13 patients on the ventilator today. And we have 20 admissions. That's the fewest admissions we've had in quite some time. We've been, going between 30 and 50 admissions a day. We have 46 new positive patients in the community. Not all those are necessarily hospitalized. It's important to note that of those patients that come into the hospital, 80% at both hospitals are unvaccinated patients. Unvaccinated patients. And I'll let the other physicians share with you the medications and those things. So when you look at the pandemic and where we are in the hospital, you can see that we have been severely challenged in terms of the number of beds, in terms of medications, in terms of ventilators. At sometimes, even oxygen has become in short supply. And so every day we work to make sure that we have a supply of all the equipment, the medicines, and everything we need to adequately treat our patients. And we've been fortunate to procure those resources pretty readily, but we've had to do quite a bit of work, and people have done amazing work. And the other thing I just want to really end with is that, you know, we think about beds, medicines, equipment, et cetera, for patients. This has had an enormous toll on our staff. I think, as most people know, there's been a significant shortage of nurses, and other allied health personnel, excuse me, not only regionally, but across the nation. And then this has hit us relatively hard. And if you think about a nursing shortage, it's hard to care for the patients. So many of our nurses have worked extra shifts, doubled up on their time, done an amazing job. They've been really impressive. But I also want you to know that each day for the last few weeks, we've had anywhere between 45 and 60 staff members out with COVID. And that, it really is really hard to overcome that kind of hole in the nursing ranks and other ranks to really deliver the care. So that has added a challenge that you know, is really of huge magnitude for us. So just to have enough staff and enough beds to care for the patients has been a major challenge. So from my perspective, the pandemic has, you know, really challenged all of healthcare in this area. But I do want to really point out that my colleagues who are on the front lines, these guys, I'm not on the front lines. I'm looking and trying to procure resources and making sure that patients are getting appropriate treatment. But the nurses, the LPNs, et cetera, that are on the front lines, the physicians on the front lines, have done an amazing job caring for these patients and getting these patients at the right place at the right time. The appropriate patients need to get transferred for escalated care. They go to UF Health Shands. We've been able to do that on occasion. But it's all because of the work of the people on the front lines that are dedicated, working more than triple overtime. You know, really, their commitment and dedication to the patients is really admirable. So I thank them for that. And I think with that, I'll stop.
Thank you very much, Dr. Burns. I just want to point out that we are following guidelines here. The room is really large and doors are open. The speakers are vaccinated and they're distant. I did consult with Dr. Maroon to make sure it's all safe because you might, so the reason they don't have their mask when they talk is just make things clear so you know, people can understand what they're saying. So now I go to Dr. Bhatt, who will give us his experience about you know, critical care management. And I would like him maybe to talk about the masks because there's a lot of myth about using masks, CO2. So maybe you can give us an idea about that. We had those questions. Some of your questions might be answered by what they say now, but then we'll go to the questions that have not been answered, and we'll answer them. Thank you.
So I kind of wanted to go over a few things that we do in the ICU to begin with, just so you guys have an idea. In the ICU, you know, treatment-wise, I'll leave it to Dr. Maroon. But you know, in the ICU, our main goal is to make sure we give adequate oxygen because a lot of these patients come with low levels of oxygen hypoxemia. That's low-level oxygen in your blood. And the treatment can range from different just nasal cannulas all the way to high-flow nasal cannulas, non-rebreather masks, positive pressure, PAP therapy, which is well known as CPAP or BiPAP, and then mechanical ventilation, which is the invasive ventilator or intubation. The various other treatments that we've learned that potentially help the patients is proning, something that we found is very effective early. This basically means sleeping on your belly or your abdomen for long periods of time, usually typically hope for at least greater than 12 hours. And this can help even people that are not in the ICU, so it's something that we recommend if you are sick, that we really push hard for even when you're on the floors at home. But typically in the ICU, that's what we try to push hard for. The one thing that I kind of wanted to talk about more also was, I feel this is not talked about a lot, is what the patient actually goes through in the ICU. Typically, if you get COVID-19, unfortunately, and you are sick enough and you come to the hospital, get admitted, you are admitted to an isolation room. So that usually means you're alone in the room by yourself. You do have your cell phone, other things, if you'd like your iPad, things like that. You have a TV. If you're on the regular floor, you may have a bathroom. If you're in the ICU, it's usually a bedside commode. And if you're very, very sick, very short of breath, then a lot of the times you would need a bedpan and help from other professionals, which is something very important to think about when patients in that position. So you're in isolation. There is limited contact with other humans in general. You have nursing staff that come in, you have respiratory therapists that come in, we have doctors that come in. We spend time with the patient. Every time a nurse comes in, they try to be as efficient as possible, do a lot of the things at one time, giving meds, bringing the food tray, things like that. You decrease the amount of the time that you decrease the amount of times you have to enter the room for multiple reasons. You're trying to preserve PPE, and at the same time, you're trying to be more efficient, and most importantly, you're trying to protect yourself. So putting all this together, you're looking at a patient that's in isolation that has limited contact to human people. And every time you see someone, they're basically decked top to bottom, completely covered up, so you don't know what the person looks like, which is very, very difficult. Now, statistically, if you're admitted to a hospital, non-ICU, you're looking at least around a 6-day hospital visit. If you do get admitted to the intermediate care unit or ICU, you're looking at around 10 to 14 days at least. That's the median length of stay in the hospital. So now things get more in perspective. You're alone, you get to meet people here and there, but now the time. And when someone's in the hospital, sitting in one room, all he's got is a TV, your brain starts playing tricks with yourself. It gets very, very frustrating. A lot of the patients get very upset because they're not getting well. They feel they should be getting well sooner. And unfortunately, this is not like a bacterial pneumonia where you give antibiotics, 2-3 days you start getting better and you're ready for discharge. This is more of a marathon and than a race, and it's very, very difficult on the patient psychologically, which is something that I really wanted to point out. Now, the one other aspect of this is you don't have your own family next to you trying to coach you through this, and that's very difficult. You are looking at other practitioners, and this is where I want to commend the nursing staff and the respiratory staff. They have stepped up to try to fill the void of a family member. You can try to be a friend, but again, I want to be very clear, it's very hard to replace a family member, which is what these patients are struggling with, and that's important. Now, that's the patient's perspective. I have talked to many family members who are in the ICU, or whose family members are in the ICU, trying to explain things to them. And I have kind of, over the last year, learned what they go through. This is a very difficult situation for them. They get to talk to maybe 1 or 2 people, maybe get a call once or twice a day. And if the patient is very sick, they don't get a call or a text or anything, or maybe they just get 1 text a day. This is extremely traumatic psychologically to the family members that are not in the hospital, seeing their family members at bedside, which is very important to understand. We try our best to explain what the family members are going through. We try to explain to the patient and try to be there for the patient in the most passionate and most empathetic manner as possible. But it's very difficult. We can't replace a family member. Now, this is very difficult, and I want to make sure that people understand that psychologically it's hard for both the patient and the family. Statistically, we're looking at least 15-20% of all the admissions that get admitted to the ICU. Unfortunately, a lot of the ICU admissions we're seeing now are very young people. Recently, I was at the Villages Hospital. We're looking at around 50% of the ICU patients from COVID-19 specifically, not everyone, just COVID-19, are less than 55. And this is very hard. This is very, very young population. If you look at the demographics in the villages, this is staggering and very, very concerning. And all these patients are unfortunately on the ventilator. So these are some of the few things that I wanted to kind of go over and make sure you guys get the idea and the perspective of the patient. And all of this, in our opinion, or my opinion at least, is preventable. We can do something to prevent being in that position for the patient, for the family members, for everyone involved. And that's very important to understand, that we can prevent getting there, not worry about the treatment that we get when we get there, and worry about researching the treatment that, hey, when I'm in the ICU, I want certain things to be done. Why put yourself in that position in the first place? And that's what I want to make sure that people understand. Now, kind of as what Dr. Hussain alluded to regarding the masks. So there are a lot of myths going around, concerns rather, that oxygen levels drop, maybe your heart rate goes up, or carbon dioxide levels go up. And I can tell you that none of those are true. There was a recent study that was in JAMA that did suggest maybe carbon dioxide in children do go up, but that has since been retracted. And there were many, many faults and flaws in the study, so that's why that study is not valid, and I want to make sure people understand that. There could be a very minimal amount of carbon dioxide, because when you're breathing out carbon dioxide, it mixes with the ambient air, and the levels go slightly up. But physiologically, is that causing any problems or harm to the body? No. In my opinion, very less likelihood. So it's important that we wear masks. Why is it important at this particular time? The risks of not wearing a mask means we're transmitting this disease. If I were sick or something like that, and I didn't have a mask on, I would be giving it to other people. And if the person in front of me did not have or had a mask on, they would protect themselves. So you're basically protecting each other by wearing a mask. And at this time, the benefits of wearing a mask by far outweigh the risks of it, if they are any at least. And that's something that I want to make sure everyone understands. I think otherwise, those are kind of the points I wanted to hit on. Regarding the treatment-wise, I'll defer it to Dr. Maroon over here. Thank you.
Thank you very much. Dr. Bhatt touched on a very important aspect, which is the psychological impact, not just on the patient. I think Dr. Burns also mentioned it on the medical staff, the healthcare providers. Yesterday, a 28-year-old patient died from COVID, and the nurses were crying in the intensive care unit. And that really leaves, I really believe that after this is over, we're going to see a lot of post-traumatic stress disorder in the frontline healthcare providers because of the stuff that they see, the problems. The nursing staff and the respiratory therapists who are there with the patient all the time, the MAs, the LPNs, those are with the patient. They become attached to them, especially if they stay for too long. And it's really hard when you have this relationship and you feel you cannot do anything to save that life. And when the patient dies, it takes part of you. But the harder part is you still have to go and try and save the next patient. You don't even have time to grieve the loss of the patient that you probably took care of for hours, days. You saw them more than their family did in the last week or two, sometimes even a month. Because you have to go your job. Dr. Burns mentioned that some of their nurses are taking double shift, 3 shifts. They're mentally, the healthcare providers at the front line are really physically and mentally getting drained. And really it's our duty. These are family, our friends, our relatives that are doing that. And we really need to do our part. We have to show that we are one community and help each other out any way we can. It's really not about forcing things. It's really about trying to do the right thing. That helps everybody. I always say, wearing a mask is maybe just inconvenience if we're wrong, but not wearing it, you could cause someone to get infected and maybe not get better. So just a point. I'll get to Dr. Maroon, who actually is on call, and he's working this weekend. He's been an advocate trying to educate, so he was very kind to take time out for his day. He actually started at 4:30 in the morning, so he can make it here. Thank you, Elias. Go ahead.
Thank you. Hello, everyone. I'd like to start by saying that we, the doctors and the healthcare workers, and you guys have the same goal. We all want to get out of this alive and healthy, and we all want to be done with this. We're all sick of it. And there are a few things that probably you all heard of to help us move on. And I'm going to address two things that are probably the most controversial these days. I'm going to start talking about the masks. The mask has become very controversial within the last couple of years. And probably one of the main reasons it all started when the CDC went and told people not to wear masks, they don't work, right? And then a few months later, they changed their mind and said, you know what? They do work, do that. And I do believe this created some confusion amongst people and maybe mistrust. But I just want to defend that point or explain it, that how we do things in medicine is evidence-based. At that time, we honestly did not have enough evidence or data that show that masks work. And month after the other, we started collecting data and studies were done and actually showed that masks do work. We know that for sure right now. There's enough studies were done, enough clinical experiments, animal experiments, clinical data, and real-life epidemiologic data that happened. A lot of examples that show that masks do work, and we can see some states, the numbers before mask mandates and after mask mandate, and we see that this actually works. And the more people adopt this in a community, the better the results. It's very important to understand that. And there's a lot of benefit. Not only it decreases the risk of transmitting, we have data that shows that actually it decreases the risk of severity. When you get a load of virus from somebody else, let's say you're sick, you give me the virus. If you if you give me less virus, right? If we call that inoculum, if the amount of virus that got transmitted to me is less, right? Usually patients tend to have less severe disease. So that's one of the very important benefits of wearing a mask. And the other one, obviously, we all know it's not an absolute prevention, right? It's a risk reduction. Risk reduction is important. Some people tell me, well, it doesn't, prevent it from having it. I'm not gonna wear it. It's important to understand that risk reduction is very important. It's like your doctor telling you, well, you have high cholesterol. I'm gonna give you a pill that will reduce your risk of having a heart attack. It's not gonna eliminate it. You're not gonna tell your doctor, no, I'm not gonna take the pill, and I'm gonna take my chances and have a heart attack. It's similar. It's very important to understand that this is a risk reduction along with the other measures that we have. Social distancing, vaccination, etc. So it's important to understand that. The other thing that became as controversial, if not more, is the vaccine. Vaccine has become controversial for a lot of reasons these days. I'm not going to talk about it, but most of us know political, religious, social rights, etc. I want to take all this out of it. Vaccine is a vaccine. We survived so many years since we were kids until now because of vaccines. When this happened, everybody was praying, everybody was excited, they wanted vaccine, we want to be done with this. Actually, everybody prayed for it, I did. And then the vaccine comes out, and people start getting scared, nervous, worried, looking on social media, listening to their neighbors, their friend, the vaccine causes this and that, we don't know what's in it, there's a tracking device, whatever, reasons they started talking about it. It's not FDA approved. Well, guess what? It is FDA approved. It's not rushed. We have good data. Enough people have gotten it so we can detect the rarest side effects. So it's very important. And I'm going to be very transparent by telling you what we know about it, that what works, and what we know that probably doesn't work as much. So far, we know that COVID-19 vaccine prevents or decreases the chance of somebody getting sick with COVID. We know that. It doesn't eliminate it, it decreases it. Remember, risk reduction. The second, as important point, or probably a little more important, is decreasing the severity of the disease. People who are vaccinated have less chances of having severe disease. We're seeing that in the hospital every day. We're seeing the people in the ICU, probably you all saw on social media, the amount of people admitted who are vaccinated versus unvaccinated, or that people are in the ICU are very sick with it, vaccinated versus unvaccinated. So this second point of the vaccine is very important. The third point that could help, there's something we call long haulers. Some people who get sick with COVID-19, they have lingering symptoms of mind fogginess, tired, lung issues, GI issues. So we have some data that shows that if they get vaccinated, this could help with the symptoms. And what we know as well is that this vaccine does provide some efficacy and effectiveness against the current variant. The other thing that's important is we're having more and more data that if we give the vaccine to already infected people, it decreases their chance of getting reinfected. So if you have two communities, they all had at one point COVID-19. This community, we give them the vaccine, and this community, we don't. The people in that community who didn't get the vaccine have higher chances, about 2.3 times more chances of getting reinfected. So that's important. Now, unfortunately, we do know that immunity with this vaccine wanes over time like a lot of other vaccines. So that's one other thing I want to be transparent and for you to understand. And that's why now there's talk about and recommendation for a third dose. What we know as well, unfortunately, there are some rare, and I emphasize on rare side effects. We know as well that there are rare potential anaphylactic reactions, allergic reactions that are very easily treatable and reversible. We know that. But we also know in medicine, the way we practice is all about risk and benefit. When the benefit outweighs the risk of certain procedure or certain medication, we do it. When the risk outweighs the benefit, we talk about it. So what I can tell you with 100% confidence that the benefit we get from the vaccine on an individual level, community level, country level, and God, for a whole universe, world level, that the benefit way outweighs the risk. And with that, I'll give Dr. Hussein probably for questions, and we can elaborate a little more.
Okay, thank you very much, Diaz. I mean, one of the things that I looked at, because I'm a hematologist oncologist, so we get asked about the blood clots. You know, there's some, reports of having blood clots in vaccines, and it can happen. I mean, it's very rare. It happened with the AstraZeneca and Johnson & Johnson, but the issue is that the blood clots from the COVID are way higher. So for instance, in one study, they found that blood clots from COVID were like 39 per million. Vaccine was like 4.1 cases per million. Another study, actually, when they looked at, vaccination when it started till I think around May or June, and they found they have 66 cases of blood clot in 10 million people who got the vaccine, while they found 12,614 blood clots in the same number of patients who got COVID worldwide. That was worldwide. So just like that actually shows the risk weighs the benefit. So although you can have a risk from the vaccine, which is very minimal and rare, the risk from the disease itself is way higher. And that's where you have to kind of balance and make your decision. So thank you very much. Now we can go to questions. And I have here Michelle Viveris, who's an APRN, advanced practice nurse practitioner. She also has master's degree and doctorate degree in nursing. So she will, we received some questions through the email, and we're still receiving questions. So Michelle will read the questions to the panel. Thank you, Michelle.
Okay, hello. The first question I have here is, for 17 years, I have lived with CIDP, which is a chronic inflammatory demyelinating polyneuropathy. I have been treated over 15 years with immune globulins. I continue to regulate symptoms with PO medications. Two questions are, have there been any participants in the vaccine trials with CIDP? And given the vaccine's immune response to provide immunization for COVID, would there be a contraindication for a patient with CIDP to be vaccinated?
Yes, I'll take it.
Okay, go ahead.
So CIDP, regarding the studies, I'm not aware of, in particular, CIDP patients that were, focused on or included in the study. The other part, which is more important, we know that CIDP chronic inflammatory demyelinating polyneuropathy, is a cousin of GBS, Guillain-Barré. A lot of you hear it. And we know that after some vaccine, which is usually J&J and AstraZeneca, there was some rare cases, very rare, about 100 out of 13 million doses that happened. Probably that's why the question was asked. CIDP is the cousin of GPS, like a chronic counterpart of it, if I may say. So what I would tell you, there's no reported cases of CIDP from the vaccine so far, and a lot of vaccine doses have been given, more than 300 million. But what I can tell you, if one is to be prudent, and we're gonna put them in the same category, although there's no studies to say that, since we are recommending for people who have history of GBS to get the mRNA vaccine, which is Moderna and Pfizer, probably it would be prudent to tell this gentleman to get the Pfizer or Moderna vaccine, since there's no report case of such thing, GBS or CIDP.
Okay, our next question, maybe some of it was addressed, but I'll ask it here. What is the real current status, daily COVID-19 cases arriving at the hospital, ICU bed availability, ventilators, PPE, respiratory therapists, et cetera?
Yeah, thanks for the question. So I think I reviewed the status, the current status in terms of the number of beds, but I do want to focus just a little bit on supplies, equipment, et cetera, because that frequently does make the news. So I think for most of the supplies, we've done very well. We've had some days when we're a little tight on ventilators, but we secured a supply of ventilators, so now we have an adequate and abundant supply of ventilators and the associated equipment to go with the ventilators. I think the other thing that we have noticed is that there's a drug, Actemra, that is in short supply across the country, but I credit my colleagues for finding a suitable alternative to treat those patients in which it's indicated. And so, you know, when we run short or think we're getting short on supplies, we seek alternative sources. And I must say that at the Villages Hospital and Leesburg Hospital, we are the beneficiary of being associated with and having UF Health in Gainesville because they have supply that we can tap into, borrow from them, et cetera. So we share supplies, drugs across the two sites here and also with UF Shands in Gainesville. So we've been very fortunate, I think, throughout this pandemic not to run short of anything except the Actemra, and people have done a great job. There's a whole team behind the scenes that every day their job is to make sure that we have adequate supplies and drugs.
Dr. Burns, I have a follow-up question, if you don't mind. So how did that affect other procedures, like elective procedures, surgeries in the hospital?
Yeah, thanks for the question. So you will read in the newspaper and other places that there's places have put a limit on elective surgery. We have not. We have been continuing to provide care to patients that need surgery. We're fortunate in that we've been able to utilize the operating rooms and have run at our usual capacity, but we do monitor it daily. And there could come a time when we might have to restrict the number of operations, but right now we're not doing that. We've been able to offer every patient that needs an operation. So again, we're fortunate to have an abundance of operating rooms and other equipment and be able to treat patients. But we could foresee some instances in which care could be limited, but today we're not really facing those.
Yeah, one of the things that we noticed with the surge last year in the cancer part, that we have more patients who presented with more advanced cancer because they couldn't get their screening. Not because it wasn't available as much as they were afraid to go to medical facilities to get their screening. Happened with breast cancer even. And I know from my cardiology counterparts, cardiologists, they said they noticed the same thing with patients coming at the almost end stages of heart attack, where they have to either they could die or they have to go through a cabbage, where they could have been saved by just a simple stent. And again, it's because, you know, when a patient, and we love this, patient call you, I have this, well, you need to go to the ER, like, I'm not going. I don't want to get COVID, like, you know, so there is that fear of trying to get COVID. And I usually tell them, you know, actually, that might be the safest place to go to because they're very careful and about sterility. So I don't know if you want to comment on this.
Yeah, I am concerned that patients are delaying care and necessary screening, et cetera. And so I do think that as our capacity improves, right, it's an important message to say it's, you know, we're open for business, right? And we want to be able to evaluate you, diagnose you, and take care of you, and really encourage patients to get back in the flow of their regular doctor visits, their regular screening examinations. And I think it'll be important for us to be transparent about what's going on in the hospital, you know, and how many COVID patients there are, and how, you know, we segregate COVID patients from other patients as the numbers decrease.
I want to also use that Actemra story because I think that's very interesting, where it's really like you feel like you're fighting in a war. You get a shortage of a weapon and you try to find another weapon. So maybe, Dr. Maroon, you can tell us a little bit about what you guys did.
So I didn't want to go into detail on the treatment, but what I would tell, you know, I want to tell you guys that I don't want you to feel comfortable. Look, we have treatments for COVID. You know, great, if I catch it, I get sick with it, I'm going to get treated. I want you to understand that it's not this is not a situation where I have a bacterial pneumonia, here's antibiotic, you get better, you move on, life is good. It doesn't work like that. Antivirals are trickier, and the COVID treatment that we have are not great. I don't want you to have this, you know, illusion that, no, we're going to get, treatments are trickier. We don't have great data about them. They don't work great, okay? What we know works great is the vaccine. The best thing is prevention. Once you have it, it's not that easy. Treatment is not a simple thing, you get it, you get better. No. You would linger for weeks sometimes. People will be ICU or on the floors, short of breath for weeks, imagine. So don't have this illusion that the treatments are great. They're not. They're decent. We have some decent results, but it's not great. So I just want to make sure that people understand that they don't feel very comfortable that the treatment exists, that, you know, if we get it, we get it. No. Vaccine is, we have much better results in prevention of severe disease and death than the treatments that we have currently for COVID.
And many of those treatments are not even FDA approved, unfortunately, because we have limited data. But my point was, like, you know, sometimes when we're desperate and we know that something may help and we don't have it, we try to find an alternative just to try to minimize the inflammatory response. Other questions, Michelle?
We have a question here asking, can you explain what antibody-dependent enhancement means and give some history of this? How might this relate to COVID viral loads in the vaccinated?
So antibody-dependent enhancement is, we see that in some viruses where people are exposed to a virus, let's say dengue, and then they form antibodies, but the antibodies they form, usually they're suboptimal. They're not neutralizing antibodies, very well neutralizing antibodies. And then the next time they get it, they are exposed to this virus, these people could be more severely ill. They get a worse reaction. So sometimes we see that with some vaccines. We give the patient a vaccine, they develop antibodies that are they're suboptimal, and then they have a worse disease once they're, you know, exposed to the virus. So we saw that it happened with other viruses in the past. I think dengue, RSV, and measles maybe in the past. And they were taken out of the market. So and usually we see that right away. In this case, it's the opposite that we're seeing. We're giving the vaccine, and we're seeing that people who are vaccinated are doing much, much better than unvaccinated people. So I'm glad I got to explain what ADE is, but regarding this question, no, it doesn't work. There's no ADE with the COVID vaccine, I can tell you with 100% certitude. Otherwise, we would have noticed the opposite.
I have a lot of questions here asking about the booster and when people should get it. Should they get the same manufacturing vaccination they had the first time? How long should they wait? And if they're immune compromised, should they get it sooner?
That's a lot of questions. So,
Yeah.
so I'm going to start with right now, yes. The booster is recommended for immunocompromised people. And this, patients should talk to their doctor to see if a lot of people think they are immunocompromised, but they're not. We're talking about organ patients on certain medication that will compromise their immune system. So for these people, we're recommending a third shot because the data showed that they're not mounting a good antibody response. So for these people, they should talk to their doctors, and if they're considered in this category, to get the third shot. The third shot is recommended to be taken about 4 weeks or 28 days after the second shot, at least. So if you got the second shot in March, anytime like after 28 days or later, you can get the shot. Regarding the which shot, what's recommended right now is to get the same shot. So if you got Moderna, you get Moderna. Pfizer. There's going to be more data later that might change, but right now we all know that medicine is dynamic. It's not a static thing. We make a decision, we stop. There's always data coming in, and the more we find out about the virus and the vaccine, more recommendation will happen. So for now, this is what's recommended.
And this was another question that was asked earlier, as far as the Johnson & Johnson, which is a different technology and only had one dose. Is there any booster recommendations for that?
Not for now. Not for now. But probably because it started later, probably the recommendation is going to come later.
Okay.
Doc, I have a question for Dr. Bhatt about the critical care intervention. I mean, a lot of people ask about ECMO. They asked me personally. It was an email. So can you elaborate on that? And because some feel that, okay, once you get ECMO, then that's it. You're going to get better or be back to normal. And if you can elaborate.
So ECMO is another. It's something that we have, or not we don't have, but have availability to at Shands, where you basically replace the lungs, or in some cases the lungs and heart. In this particular disease, we replace the lungs and get the patient oxygenated. The idea is to get the lungs adequate rest. So the more the lungs work hard, the higher the amount of inflammation and possibly more damage, irreversible damage. So you're trying to prevent that. So you're trying to make sure that the lungs don't do any work for X period of time, while they're on this machine that's doing the work for them, giving them a good amount of oxygen. Is it 100%? No. Is someone getting on ECMO always going to come out all right? No. Have we had good outcomes? I think myself and a colleague, we did send a few younger patients that did go to Shands, and one of them, the one that I sent, I want to say 3 weeks ago, did actually come back, and he's doing a lot better. He's on 2 liters. So it is helpful. But again, it boils down to one thing. Why put yourself in a situation where you're putting your body through this much rigorous treatment over 3-4 weeks when you could spend that time with your family and be there with your family instead of being in hospital, putting everyone through a lot of trauma.
Thank you. Michelle, you have to.
Okay, next question. Have there been fetal cells used in the development of the COVID vaccines?
So the answer is a little tricky, but I'm going to say yes. Because to understand that, I just have to go a little in the background of fetal cells and how it's done. So the fetal cells, when we say were used, one abortion happened, let's say in the 70s or 60s, right? And then it was an elective abortion, and then the tissue, we used that fetus, right? And the cells were multiplying. And right now, in 2021, we're 1,000 generation of cells away from that fetus. I wanted to start by saying that. Now, there's 2 stages when we talk about fetal cells. There's research and development, and there's manufacturing and production. For the Moderna and Pfizer, initially in the early stages of research, yes, they use fetal cells to see if we inject them with the mRNA, are they going to use it? They're going to make their own spike proteins. So to see if this works, it was used. But then after that, in the production and manufacturing, no fetal cells were used. So when you get the vaccine, you're not getting injected with fetal cells or anything like that. In the early stages, it was used, but right now, no. Now, regarding, we use in the States Johnson & Johnson, for the production and manufacturing, fetal cells are used, okay, for the vector. So we have to understand that. Now, knowing that this fetus is one, and we're decades ago that happened, morally and ethically, I think this goes to like everyone has his own opinion, but I do believe that most of the churches, the Catholic Church, I believe the Pope, not only say it's okay to use it, they encourage people to get the vaccine. Some of them say try to be as distant as possible. So instead of, for example, Johnson & Johnson, use Moderna and Pfizer, that's okay. But they encourage people to get the vaccine as an act of love, loving your neighbor, etc. So yes, they were used, but at different stages, and we're not getting fetal cells in us if we get the vaccine. So just to make things clarification. I digressed a little bit, but just to give an idea.
Thank you.
Okay, we have a question. What are your recommendations for children under 2 in daycare that can't get vaccinated or wear a mask?
Dr. Bob?
So the reason I feel, I do have a son who's 19 months old, and I'm in this situation where it's very difficult. It's very difficult for a parent to make this decision because you don't know what's happening at a daycare, school, or anything like that. So everyone's opinion, every parent has to make the right decision for their child, and I would defer it to their parents. But what I do is, as what Dr. Maroon alluded on before, it's all about risk mitigation or risk reduction. I want to make sure that my child is safe. I got the vaccine, my wife got the vaccine, my parents, my brothers, her sisters, everyone that possibly gets in contact at home have got the vaccine. Now, when the case started going up, I was obviously concerned. I did take him out of the daycare for a week or two just to kind of assess the situation. There's some people that are not fortunate enough to do that, and they have to send the kids to daycare. That's where when I waited and I looked into the daycare a little bit more, everyone there, the teachers were all wearing masks. I couldn't ask, and it's not fair to ask if they were vaccinated or not, but I'm hoping that they were. I'm hoping that the kids that my son is playing with, interacting and learning from, their parents are vaccinated or their loved ones are vaccinated. And ultimately the goal would be, everyone that could wear a mask wears a mask, and everyone that can get a vaccine gets a vaccine, so we protect the people that cannot. And that's the most important thing.
Yeah, I really want to emphasize that. The idea of getting the vaccine is not just to protect yourself, because some say, well, I'm healthy, I never got an infection, but you're really protecting others because you could get the virus, not feel anything, and spread it. I deal with cancer patients, we give them the vaccine, but not many of them may not mount the immunity to fight the virus if they get the infection. So it's really very important to be in a society or in a community, like in their household or wherever they go, that people are vaccinated and using mitigations, like masks and social distancing, not to be in a large group of people in closed spaces. So that's our duty as a community, to protect each other. It's not just protecting yourself, you're really protecting other people in your community that are not as fortunate or just can't either get the vaccine or mount an immunity from the vaccine to protect themselves from the virus. Question?
Does the Regeneron monoclonal treatment have full FDA approval, or is it still classified as emergency use authorization?
It's still considered EU, emergency use authorization, EUA. But soon it will happen.
I have a question asking about the history of the mRNA technology. Can you please confirm how long the technology has been in development? What other illnesses has it been used for? And what is the expectation that it could be used for the flu and other infectious diseases?
So the mRNA technology has been used for decades. I don't know the exact year, but I know for sure it's decades. And not only in my field, Dr. Hussein's field, it was used for cancer research. So it's been used for Zika virus, flu virus, I think rabies. So it has been studied for decades. Now the other part of your question, if we think it might happen, I've been reading a lot of articles, and I think Moderna and Pfizer are working on flu as well, and I think either Moderna or Pfizer are working on a combination flu coronavirus. So yes, I do see it happening in the future. So if this person trying to put money on stocks, yeah. But, so I do think it might happen.
Yeah, it's actually been studied in cancer vaccines, the mRNA, and I think it's at least 20 years research. I think in the mid-90s is when they started doing the research, maybe even late 80s. But the application has been just lately, around 10, 15 years, where they try to apply it in cancer vaccines. And it doesn't, maybe you want to talk about that. It doesn't stay, some people say it changes your DNA or it stays in your body. So mRNA get degraded after it's stimulated.
So the mRNA goes into the cytoplasm. It doesn't go inside the nucleus where the DNA is. This has no, that's basic science. So I can tell you with 100% certainty that it does not go or alter our DNA or nothing like that.
Thank you.
And regarding to Regeneron, is it recommended for anyone who tests positive with COVID-19? Is it as effective on patients with the Delta variant? And do vaccinated patients respond better when they get Regeneron?
If you split it into three, so the first part.
The first one. Is it recommended for anyone who tests positive?
So there's a list of recommendations for Regeneron. Usually they have to have certain factors like age is a big, more than 65. If you have other, and it involves a lot of the part of our community, heart disease, obesity, diabetes, high blood pressure, a lot of the factors, I don't have the list off the top of my head, but a lot of the factors are...
There's a criteria they look at.
There are criteria.
Depending on the criteria, if the patient has those criteria, then... So the answer is no, not every COVID positive will benefit or needs the Regeneron, but there's certain criteria if they meet, like if they're immunocompromised on high dose steroids for a long period of time, or even like how their oxygen saturations or X-ray findings. So there are different criteria they look at.
So the point of Regeneron is to prevent progression to severe disease. So we chose basically the population that has high risk of progressing to severe disease, which is the criteria, the age, the immune system, diabetes, heart disease. These are the people who have high risk of progression, and that's why we give it to these people.
I just wanted to add one thing, actually. One thing that people don't know, pregnancy is also one of the reasons to get Generon, which is important for a lot of the younger people to know.
And vaccines are safe in pregnancy?
Yes.
Vaccines.
They're safe in pregnancy, yes. We have decent data that shows, I think 2,500 pregnant women, there was no risk of miscarriage as opposed to the others. So we have enough data to recommend vaccination to pregnant women to prevent the complications that could happen if they're not.
Actually,
there was a part of your question that we didn't address. I don't remember.
They asked, is it as effective on the Delta variant?
It's still effective. And there was one more.
Do vaccinated patients respond better?
Good. That's a good question, actually. We don't know if they respond better or not, but we're recommending it. So it's a tricky question because we don't have enough data. The Regeneron came out before enough people got vaccinated. So we don't have enough data to see if vaccinated people taking Regeneron do better than unvaccinated people taking Regeneron. There's no comparative studies, but what I want to make sure is clear that we still recommend it. Even if you got the vaccine, you got COVID-19, you have the factor, we're going to give you the Regeneron to decrease your chance of progressing. Because some people, we don't know if they mount a response. So we cannot assume that everybody, if this person, even though he's vaccinated, got COVID-19, if it's mild, we're going to give them to increase the chance of protection and make sure he doesn't progress into severe disease.
One question about since you mentioned pregnancy, some ask about the infertility, and there are no reports of infertility with the vaccine. I actually know people who got the vaccine and did get pregnant afterwards. So that's.
So do you want to elaborate on that?
Please. Yeah.
Okay. So regarding the fertility, it started with a piece of information came from Germany that there's a syncytin 1, we call it. It's present in the placenta that has resemblance to a spike protein, and basically there was an amino acid sequence that's similar in both, but it was short. It was too short to make our body confused by creating antibodies against that molecule syncytin. So it's very important to understand, and I always give the example of, for example, myself, my phone number has a sequence of 357. Dr. Bad's phone number has 357 as well. So if anybody tries to call my number, they're not going to get to him just because there's this sequence. It's short enough out of the whole phone number. So what I want to tell you, and basically in the initial studies for vaccination, women did get pregnant with no problems. And right now we have enough enough information. A lot of people got the vaccine, more than 300 million, right? And we have a passive reporting system we call VAERS, Vaccine Adverse Event Reporting System. And not only, there's over-reporting on that. So trust me, if there's any problem with pregnancy, a lot of people are gonna report there. So there's no such basis to this information. Vaccine does not cause infertility. Thank you.
I just want to add one more little thing as we're talking about pregnancy and things like that. Getting the vaccine while you're pregnant, at least towards the end, if you have the antibodies and after you do give birth, the first 6 months are very important for your child. They don't have an immune system or they don't have a strong immune system. So it's your antibodies that the mother gives through the breast milk to the baby that protects the baby. So actually, to help your own child, it's very important. To protect him or her, it's very important to get the vaccine and have the immunity.
I have a question perhaps for Dr. Hussein. I have multiple myeloma. Is it safe to undergo a bone marrow transplant? The concern is for loss of immunity until vaccines can be re-administered several months after the transplant.
So for bone marrow transplant and something called CAR T therapy, which kind of wipes out your immune system, they don't recommend any vaccines for 6 months if you go through the transplant. Now, it is recommended to get the vaccine before the transplant. You can still mount an immune response, and the antibodies will last. So even if you go through bone marrow transplant, the transplant process is not going to wipe out your antibodies, might wipe out your immune system so you don't have a response, but it won't wipe out the antibodies. So it's really recommended to get those vaccines before you go through the transplant process.
Dear scientists, I would like to know if I have chronic urticaria, can I get vaccinated without having any risk?
Yes. I mean, you're going to have the same risk than the rest of the population, right? Small potential, fever, body aches, etc. As a risk, there's very rare side effects or anaphylactic reaction that are very, very rare. You're talking a few cases out of millions, but her risk is the same that my risk or somebody else who is healthy. There's no increased risk just for having chronic urticaria.
There are several questions, maybe the same question. Can a vaccinated person be asymptomatic and spread COVID-19?
So we know that, yes, that now we're having more data that vaccinated people can have the amount of virus as others. But what a lot of people forget to mention, or they don't mention, is that the vaccine itself decreases your chance of getting COVID sick or asymptomatic. So the fact that this amount of this population is less, so there is less of a chance of vaccinated people transmitting it. You understand what I'm trying to say? So that's very important to understand that. Yes, we know that vaccinated people can transfer the virus, but there's less people who will have this opportunity to transfer it if they're vaccinated. So in a way, it does protect.
The amount of being contagious is also less. So I think like an average, if you're vaccinated, I saw just one study mentioning like 2.4, a vaccinated person can infect 2.4 while the non-vaccinated Delta variant can infect like around 8.
This data is still figuring out, it's not very solid.
Right.
So there are some other data that shows that it could be almost the same viral load actually, but less people will get that if they're vaccinated,
right.
And that's very important.
And it doesn't
the pool
last long
overall
in
is less, a smaller pool.
Yeah, right.
Would you like to address the people taking ivermectin and any risks or benefits?
So regarding the ivermectin, there's no good studies that show that ivermectin works. It's very important. There are some data. If you go online, you might find some data, but you have to know how to interpret a medical article. The data that was done was poorly done. It was a small sample, or there was a lot of confounding factors, or people were taking other medication at the same time. I don't want to go into details about dissecting the articles, but there's no data that shows that work. That's number one. Number two, please do not take ivermectin from from your animals, because the doses are mega doses for a horse or a cow. It's huge doses. We're seeing toxicity and it's being reported. And number three, a lot of the patients we're seeing in the hospital were already started on ivermectin as outpatients. They're coming very sick. I don't have any evidence that it works. We don't prescribe it, and don't take it on your own. So right now, there's no evidence that ivermectin works.
I just want to correct something. The data I quoted, like 2.428, is actually the old variant versus the new variant. It's not vaccine versus unvaccinated.
Is there a standard protocol given to each patient who presents with advanced symptoms?
I mean, I can talk about the medical therapy. So we have criteria for certain medication that we use. The medication we have are not a lot. Basically, we have an antiviral, which is called remdesivir. We have steroids that we give. So once your oxygen level drops to a certain level, below 94, or you require oxygen, there's remdesivir, which is an antivirus. We give steroids as well to calm down your immune system. There's other things that we use, such as Actemra, tocilizumab, which is an interleukin-6 inhibitor, calms down your immune system, if I want to oversimplify it. And another one is called baricitinib right now, which is JAK inhibitor, almost the same mechanism, a little different. But so basically, we have remdesivir, steroids, Actemra, and baricitinib. These are the things, alongside the oxygen and the respiratory support. Probably Dr. Bott will talk about that more. But yes. You can talk more.
No, as in, I agree with everything you said. As in, regarding the oxygen therapies, I did talk about it a little earlier. I think it's very important to understand that there's no evident cure for this. These things can help, and we hope that they help the patients. But obviously, as you can see, the way things are going, it's not 100%. It's by all means, it's not 100% at all. So one thing we do know is vaccines do help a lot. So that's something we'd leave it.
Yeah, I think it's important to just note that none of those medications were designed specifically for coronavirus, right? They're used, they can have some effect. And the only treatment that's designed for the coronavirus is the vaccine.
Thank you. That's very important. Yeah.
Is pneumonia the cause of death, and is it because the patient waited too long to get treatment?
I'm sorry, can you repeat the question if you don't mind? What was the question?
Well, maybe Dr. Bott can assist. The pneumonia is the cause of death.
So,
yeah.
I guess the pneumonia, it's basically, pneumonia is just an inflammation in your body caused by an infectious source. Could be bacterial, could be viral. In this case, it's viral. And the pneumonia causes low levels of oxygen, which ultimately puts the patient in different organ failures. And that's what causes the patient to succumb to death or injury from that. The primary cause is hypoxia, decreased oxygenation, or decreased oxygen in your blood, which causes decreased oxygen to go to various organs of your body, including your brain, kidneys, and the rest of your organs. And that is what causes a person to fail. You can elaborate on that if you'd like.
No, that's good.
Thank you.
Thank you.
I'm a chemo patient and I had COVID in April. I have not been vaccinated and I'm concerned that I am bringing another element into my treatment by getting vaccinated. What is your opinion?
It really depends on the type of chemotherapy that the patient is receiving. We do recommend it. The NCCN guidelines do recommend vaccinating patients on chemotherapy. It's just the timing when to get the vaccine. So if you want to vaccinate when someone's chemotherapy, you want to make sure one of the side effects of chemotherapy is can drop your blood count, so patients can become immunocompromised because they don't have white blood cells, and that can recover. So you have to make sure when they get the vaccine that they have enough or their white blood cell count has recovered so they can mount a response. I do recommend it to my patients, and we did provide the vaccine to a lot of our patients who are on chemotherapy. And actually, we fought for this because we can time it the right way, so we can have that control of timing instead of them trying to go to a pharmacy and not hard for them to get appointments. So the answer is yes, but please consult with your oncologist because, again, it depends on what treatment you're getting.
I've had a few questions asking to address the staff at the hospital if they're vaccinated or what kind of requirements there are.
Yep. So when we look at the staff, we break it into physicians and to the other staff. So the group of physicians that work at the hospital are largely vaccinated. When I say largely, like probably 80–90% are vaccinated. The staff, however, has a much lower rate, and that rate is somewhere between 50, probably around 50%, maybe a little bit over that. So in the last 2 weeks, UF Health has a new policy that if staff are unvaccinated, that they need to wear an N95 mask throughout the facility in any clinical care area of the facility. The N95 mask is the best mask to wear. It's the least porous, if you will, and it's quite protective. So UF Health has made the decision to take extra measures to protect both the worker and the patients and people in the environment for those that are unvaccinated. If you're vaccinated, you get a little sticker that you can see right here on my badge to indicate that you're vaccinated. So I think, you know, as the pandemic continues on, you know, we keep evolving and adding measures that try to protect the entirety of our community, our workers, our patients, et cetera.
And by the way, it's a cool sticker. It says hero, so nice to have. Go ahead, Michelle.
There's a couple of questions related to people who want to be vaccinated, but they have concerns about a history of allergies to other medications or vaccines, and you might have touched on that a little bit, but any recommendations for them?
So there's no contraindication for vaccine. There could be an anaphylactic reaction with a vaccine, but it's very, very, very rare and easily treatable. And that's why we watch patients after they get the vaccine. So the benefit of getting the vaccine outweighs the risk of the small, potential, rare risk of allergic reaction. So I would encourage this person to get it. Now, when you say that patient has a history of allergic reaction, we have to know to what. And usually what we do precautions if they have a history of allergic reaction to other vaccines. And if we do know that the person has an allergic reaction to a component of the vaccine like PEG or polysorbate, and that's a different situation. At that point, they have to see an allergist to see whether they can take it or not. But if a person has a random allergic reaction to other things, let's say peanut or something else, that's not a contraindication. And the event that anaphylactic reaction happens, it's very rare. So yes, I would encourage that person to get the vaccine.
One final question we just got. Could you please recommend or comment on anticoagulation after discharge?
Dr. Bhatt, you wanna?
Anticoagulation drugs at discharge.
It's not recommended wholeheartedly. Initially, we thought that patients who got COVID-19 would definitely get blood clots, and we would start treating them with anticoagulation. There's no strong data to suggest during, before, or after they should stay on long-term anticoagulation unless they do have a blood clot diagnosed in their legs or inside their lungs. But what is routinely given in the hospital, which is very important, is prophylaxis doses, lower doses that prevent that prevent getting blood clots in your legs or in your lungs.
Yeah, so really, I agree. I think the only indication is if they had a blood clot in their lung or anywhere, then you treat it just like you treat any other blood clot, but otherwise there's no role for anticoagulation after discharge.
I have one last question, maybe for Dr. Hussein. Nodes under the arms and mammograms and concerns with that.
It's funny, with they get like a CAT scan or a PET scan or even a screening mammogram, and they notice that there are lymph nodes that are either active on a PET scan or a mammogram shows lymph nodes in the armpit. And then, we scratch our heads, oh my God, the disease is back. but actually it's the effect of the immune system. So if a patient gets vaccinated, we recommend that they wait unless it's really urgent and needed, and you have to take that into consideration. So if you have a patient who needs a screening mammogram, if it's just screening, I would wait a few weeks after the vaccine and do like maybe an exam, make sure there's no palpable lymph nodes, or at least let them know that you just got them into consideration. We really noticed, I think after this, different things we noticed, their counts can go ones which are the disease, some tumor markers, patients clinically doing fine. So there is a screening mammogram. If the test is not urgent or can perform the test. Okay, is that it?
I think that's all the questions we have.
Okay, well, I will end it. First, I would really thank you again, Dr. Maroon, Dr. Bhatt, and Dr. Burns. Thank you, Michelle, very much. Thank you, Sandy, for your help, Mark, and Amanda, our unsung heroes behind the scenes to help this happen. I would really like to thank my colleagues with the Florida Cancer Specialists because they supported organizing this program. I try not to ask them for money, but this time they were okay with it. And also like to thank Lakeview Healthcare System, Leesburg Partnership, the City of Leesburg who provided this room for us. The doctors like Dr. Maroon and Dr. Bhatt every day. If you have to go there, I hope the numbers keep going down. Decided in June and see what happens. So we have to get socially distance. It's not just one thing. So thank you very much for listening, and thank you again for coming here.